injury is what we call inflammation. Okay? Now, that inflammation can be acute or chronic, and the difference is days of onset. Acute is in minutes, hours, days, while chronic is weeks, months, and years. Okay? So the acute inflammation is that rapid response. Something, a bee has stung you, something has bitten you. So that kind of immediate reaction to that injurious stimuli is what we call acute inflammation, which happens in a matter of minutes. Okay? Now, this acute inflammation has got what we call cardinal features. It has got cardinal features. What are those classical features that make up what we call acute inflammation? Before going into that, there is what I would think is obvious. What are the causes of this inflammation? Anything that causes tissue injury. Anything that causes tissue injury. As long as you don't forget the major ingredient words in inflammation: vascularized tissue, non-specific response. When you say that, you have all the answers. What are those that can cause this type of inflammation? All things that can cause tissue injury. They could be physical agents, where we have the mechanical agents like fractures, sand, thermal agents, that's excesses of temperatures, gases, biological agents, where we have got infectious agents. That goes without saying. They are the same things that cause cell injury. If you remember what last week we talked about cell injury, the same thing that cause inflammation are the same thing that cause cell injury or probably cell death. We also have endogenous causes, those that arise from within our bodies, like a clot forming, a tissue dying, what we call infarction, reduction of blood supply to any organ, okay, deposition of metabolic byproducts like uric acid accumulation in joints to form what we call gout, leaking enzymes like leaking pancreatic enzymes that digest our tissues. There are classical cardinal signs that make up acute inflammation. There must be redness, there must be swelling, there must be heat, there must be pain, there must be loss of function. These are 5 cardinal features of inflammation. These ones make up what we call acute inflammation: redness, swelling, heat, pain, loss of function. Okay? This inflammation to take place, there are phases. We have got what we call a vascular response, cellular response, changes in metabolism, then tissue damage and tissue repair. These follow each other. The very first step that happens when you get an injurious stimuli is if your blood vessels respond to that. How do they respond? They respond by vasodilating, vasodilatation. The blood vessels get big. Vessels in that area, they get big. And the dilatation of the blood vessels in that area is the cause of reddening. That means that blood circulation there is much. It is the cause of heat also. Okay? And because these blood vessels are dilated, that means they become even highly permeable, and the fluid component, plasma, will ooze out. It will come out through the dilated blood vessels plus the white blood cells. Then they come outside the blood vessel to attack the real area of inflammation, the extravascular compartment. Now that causes swelling. Okay? So there are phases. I said vascular response, and in vascular response, what we have is blood vessel dilatation and blood vessel permeability. Don't forget, blood vessel dilatation, blood vessel permeability. Permeability means it increases to be permeable, to allow the cells to pass through. Now, number two, the cellular response. The cells begin by doing what we call pavementing. Pavementing means they come out of the mainstream blood, they begin to pave like a pavement to move along the endothelium where they are looking for exit through the highly permeable blood vessel to the extravascular compartment. That is cellular response. And what are these cells? Inflammatory cells, neutrophils, monocytes, which reach the other tissue, which reach the injured area, and they become macrophages, phagocytes, meant to engulf the injurious stimuli and eat it up. Then after we have got the metabolic changes in metabolism, energy, use of energy, heat, then the tissue is going to be damaged by not only the injurious agent, but even the response. The fight between your defense cells and the injurious agent causes tissue damage. Didn't you hear the saying that where two elephants fight, the grass suffer? So when your inflammatory cells react the injurious agent, the phagocytosis process will cause tissue injury. And when tissue is injured, you have a tissue repair and you can get a scar or no scar if you get complete resolution. Okay. The next about 4, 5 slides will be explaining what I have been talking about, the inflammatory mediators. These are quite hard. I don't want you to struggle a lot cramming these things. Just know for inflammation to happen, they are what we call inflammatory mediators. What causes these cells to come from inside the blood vessel to the outside? That's what causes vasodilatation. Those are what we call inflammatory mediators. Mm. You may not stress so much cramming them. Just know that for all that process to happen, the process I've told you, there must be what we call inflammatory mediators. All these explain the inflammatory mediators. Maybe the very common ones that you have heard of inflammatory mediators are prostaglandin, leukotriene, and histamine. Prostaglandins, they are the ones that these NSAIDs target, non-steroidal anti-inflammatory drugs, the diclofenacs, the ibuprofens. What do? They target production of these inflammatory mediators. Because I told you that for tissue damage and all the clinical processes we feel, the headache, the pain, it is the fever, it is because of the inflammatory mediators. Your body will secrete inflammatory mediators to prepare for response. Now you suffer the consequences of inflammatory mediators. And that's why we use the drugs we use are meant to block the inflammatory mediators. The prostaglandins, we use the NSAIDs, non-steroidal anti-inflammatory drugs. The histamine, the one which causes allergic reactions, skin itching, itching eyes, asthma. So we use antihistamines. So histamine is also an inflammatory mediator. All these slides I'm skipping are inflammatory mediators. I feel like it is quite detailed for you. You may choose not to cram them. But if you are interested, you read them. So these are the responses I told you. The vascular response, number one, that is a momentarily when there is any invading agent to any tissue, momentarily your blood vessels will constrict, but that takes microseconds. Then the most important pronounced phase is when your blood vessels dilate. Okay, they dilate, and when they dilate, you get high permeability. Okay, you get high permeability. That is when the area becomes red. That is when the area becomes hot because blood is near the skin. because blood is what? Is near the skin. Then I've told you that the dilatation of the blood vessel, the high permeability will cause escaping of plasma plus inflammatory cells from inside the blood vessel to the outside, and that will cause edema or swelling. If you look at these two pictures, the one up, the one up is a normal one. The one down, look at the neutrophils outside this. There are so many compared to the neutrophils up. Hmm? That means that there is inflammatory cell exudation. The cells have moved out of the blood vessel to accumulate outside. Even when you see the arterioles, the capillaries here, they are too red compared to the ones up. And when you see the tissue surrounding the lower picture, it is more swollen, meaning it is edematous compared to the one up. That is the same explanation. Then the cellular response that follows vascular dilatation, that follows vascular response. Pavementing, I told you what it is. Cells migrate from inside the blood vessel to align along the endothelium. They emigrate, they move out. When they move out, they are called to a particular area where the injurious agent is by a process called chemotaxis, the inflammatory mediators that are calling them. And then there is phagocytosis, where these phagocytes go, engulf the injurious agent and eat it up if they can. The whole of this diagram shows you, it shows you about cell pavementing and emigration. Cell is coming from the middle of the blood. They begin to pavement or to move along the endothelium way outside into the interstitial tissue. All this is explaining what I have just said. And then that's the process of phagocytosis. But you can also get what we call systemic effects of inflammation. Systemic inflammation, not local one. So what are the clinical features of systemic inflammation? Fever. When you get fever, generalized body weakness, okay? Those are systemic features of inflammation. What can happen to acute inflammation? Outcomes of acute inflammation, what can happen? You can get complete resolution. You get, and say for example, can any of you trace where a bee stung you, many years ago? That's complete resolution. Okay? You'll pass through all that process we talked about, you'll have the cardinal features, but there will be no traceable scar. That's one way. Number two, you can get fibrosis. That area can be fibrosed. You can get a scar. That's fibrosis. And we have two types of scars. We have what we call a keloid scar and a hyperplastic scar. They are all big scars, but a hyperplastic scar is still confined to the original area of injury. That's hyperplastic scar, still confined to the original area of injury, to the margins of the wound, while keloid has become neoplastic to say, so it has grown out of the margins of the wound. Then you can get an abscess forming. You can get an abscess forming out of acute inflammation, or it can become a chronic inflammation, the one which takes weeks, months, or years. Those are the likely outcomes of acute inflammation. So chronic inflammation, let's talk about chronic inflammation. It is an inflammation of prolonged duration that takes weeks to months. And in this type of inflammation, there is co-occurrence of inflammation, tissue destruction, and tissue repair. They are happening at the same time. Inflammation is there is tissue destruction and tissue repair. Why? That means the injurious agent hasn't gone away. So all types of inflammation where the injurious agent has not gone away, it is going to keep causing inflammation. At the same time, tissue damage is undergoing. At the same time, tissue repair is undergoing. It quite commonly happens in infectious agents that infect intracellular that go inside the cell and that evade cell killing, like tuberculosis, chronic lung disease, rheumatoid arthritis, then autoimmune diseases. Autoimmune Autoimmune diseases also will cause this problem because the antibodies against your own cells are there. Because your own cells are there, they have not gone away. So they are generating autoantibodies, antibodies against own. That's what we call autoimmune disease. So once you have such a disease, you keep having what we call a chronic inflammation because the causative agent hasn't gone away. If you have got a fat plague, what we call atherosclerosis, you have a fat plague in your blood vessel, it is there, it is not going away. So you can keep having chronic inflammation. If you have calcium deposits in your organs, what we call dystrophic calcification. If you have urate crystals accumulating in the joints, gout, all that will give you chronic inflammation because the injurious agent hasn't gone away. It's not like acute inflammation where something has stung you and gone away. Okay, that is chronic inflammation. What are the cellular components of chronic inflammation vis-a-vis the cellular components of acute inflammation? In acute inflammation, the main cells are granulocytes, what we call what we call the neutrophils. The majority of the cells, the neutrophils, macrophages, monocytes. Those are cells we see in acute inflammation. Neutrophils, because they are preparing to become what? To become phagocytes. While in chronic inflammation, the majority of the cells are lymphocytes, plasma cells, fibroblasts, meaning young fibrous tissue, activated macrophages. Very important to know the different cells in acute inflammation, granulocytes, or eosinophils, neutrophils, monocytes. In chronic inflammation, lymphocytes, plasma cells, macrophages, epithelioid cells, fibroblasts. And in chronic inflammation, you also have what we call angiogenesis. There is a presence of chronic inflammatory cells with new blood vessels, meaning that the blood vessels that were damaged are getting repaired. Formation of new blood vessels, what we call angiogenesis. So formation of new blood vessels in combination with presence of chronic inflammatory cells is what we call a granulation tissue. That's what we call a granulation tissue. So granulation tissue means a combination of new blood vessels with chronic inflammatory cells. Chronic inflammation also characteristically forms what we call a granuloma. And what is a granuloma? A granuloma means that the injurious agent is going to infect your cells. It is engulfed by the macrophages, what we call antigen presenting cells. They lack capacity to eat it up, but they process it. They process its antigens and present to the regional lymph nodes. So that specific antibodies against that antigen are developed, so that interleukins to activate other cells are secreted. Now what happens is, what I'm telling you is classically what happens in tuberculosis. You inhale Mycobacterium tuberculosis, your cells cannot kill it, but there are cells which are going to capture it first and ingest it, what we call antigen presenting cells. And the antigen presenting cells are tissue macrophages and dendritic cells. Once they engulf it, they cannot eat it. They present it to the regional lymph nodes. Now, the regional lymph nodes will release antibodies against it, but they will also activate the bystander macrophages. Now, macrophages, the lymphocytes, they will come and seal off the infected macrophage. Once they seal it off, they spread, they stop it from spreading, but it may keep alive. It may keep alive inside the central macrophage. So that's what we call a granuloma. Granuloma means the infectious agent is enclosed by a ring of immune cells, chronic inflammatory cells, to stop it from spreading. That's why you will hear they tell you have got latent TB. Many of us have got the granulomas of TB lying idle in our lungs, waiting for a time when your immunity will be low and they come up. That's what we call a granuloma. Okay? That's what we call a granuloma. So granuloma means, don't forget, a ring, here it is, a ring of chronic inflammatory cells surrounding the infected macrophages, commonly seen in tuberculosis. So tomorrow I can ask you, list for me granuloma forming diseases. List for me granuloma forming. In fact, I have now asked, that is assignment of today. The assignment of today, they want to be handed in as our routine. Go and list for me all granuloma forming diseases, meaning those are infectious agents which are not easily eaten up by your phagocytes, but they are formed in a fence. They are confined in a fence to stop it from spreading. And one day, if chance allows, it can awaken and cause harm. Now, formation of granuloma also goes hand in hand with formation of what we call a giant cell. Giant cell are so many cells have come close to form a ring. Now they end up looking like it is one umbrella with so many nuclei. That's what we call a giant cell. Giant cell like is one umbrella of so many cells that came together to form a ring, and they end up look like it is one cell with so many nuclei. Call that. And under the microscope, for us who see under the microscope, this is what a granuloma looks like. You can see a ring of inflammatory cells out here. You can see giant cells in here. And in the center, you can see necrosis. Necrosis meaning that the injured cell, the cell that engulfs the mycobacteria, sometimes also ends up dying with the bystander cells. The inflammatory cells out here, the activated macrophages, the CD8 have now targeted. They have targeted the cells in the middle here that engulfed the mycobacteria, and they also die. So the central death is what we call necrosis, and in TB, that's what you call the caseous necrosis. If you remember morphological types of necrosis, that's caseous necrosis. That's how it looks like in the microscope. Those are giant cells.